Because my topic is physiological changes in pregnancy. We'll go system wise. First is cardiovascular system. In pregnancy, there is increased activity of progesterone hormone. So there's increased release of nitric oxide and prostacyclin. Plus there is decreased response to norepinephrine and angiotensin. This causes vasodilatation, which usually starts at 4 weeks of gestation. In response to vasodilatation, there's compensatory increase in heart rate and cardiac output. Plus, there is also increase in renin activity, which causes increase in sodium and water retention. So this is the reason for increase in plasma volume by 10 to 15% at 6 to 12 weeks of gestation, which increases at 30 to 50% at 28 to 34 weeks of gestation. From 32 weeks till labor, the cardiac output and the plasma volume, it remains stable. In labor, because of the sympathetic stimulation, which includes pain and stress, plus because of autotransfusion. Autotransfusion is displacement of blood from the contracting uterus into the circulation. Because of these reasons, the cardiac output increases. The cardiac output increases by 20% in the first stage of labor. The first stage of labor is from the onset of uterine contraction to full cervical dilatation. The cardiac output increases by further 50% in second stage of labor. Second stage is from full cervical dilatation to delivery of the fetus. Then cardiac output increases to 80% just after delivery, which is above the pre-labor levels. Then the cardiac output starts decreasing to pre-labor levels by 24 to 48 hours, and it further decreases to pre-pregnancy level only at 12 to 24 weeks of gestation. Because of increase in cardiac overload, there is ventricular hypertrophy, and there is because of the ventricular hypertrophy, there is annular dilatation, which annular dilatation of the valves, which presents as a mitral regurgitation and a tricuspid regurgitation, but it does not involve the aortic valve. So any aortic murmur heard should be taken as a pathological change. Anatomically, there's enlargement of the heart and the cephalad displacement. Apical impulse is usually shifted to fourth intercostal space at the mid-clavicular line. In the ECG, the following changes are noted: ST depression, left axis deviation, and T-wave flattening. Other pressures such as central venous pressure, pulmonary capillary wedge pressure, and pulmonary arterial pressure will be stable and there is no change. What is aortocaval compression? From the mid-pregnancy level, because of the enlargement of the uterus, there is compression of the IVC when the patient lies supine. So this decreases the venous return to the heart, and further it decreases the cardiac output by 20% towards the term. But this is compensated by increase in systemic vascular resistance and heart rate, and also alternate venous pathway, paravertebral and azygos system. But during anesthesia, these compensatory mechanisms are decreased or abolished, and significant hypotension, it develops rapidly. What is supine hypotension syndrome? The uterus completely compresses. When the uterus completely compresses the IVC, this causes tachycardia, which is followed by bradycardia, and which results in severe hypotension. And this severe hypotension is usually resistant to vasopressors. The hemodynamic parameters changes in the heart and the systemic circulation. In the heart, the cardiac output increases by 50%, the heart rate increases by 25%, the stroke volume increases by 30%, ejection fraction increases by 20%, left ventricular mass increases by 50%. The systemic circulation, the systemic vascular resistance, as I said before, because of vasodilatation, the systemic vascular resistance decreases by 20%. Peripheral vascular, pulmonary vascular resistance decreases by 34%. Now next is coming to the respiratory system. Because of the relaxin in pregnancy, there is increase in the relaxin activity. This is the hormone which is produced by the corpus luteum. There is relaxation of the ligaments of the rib cage. So because of this, there is upward displacement of the diaphragm, which is seen earlier in pregnancy, and the lung becomes horizontal more than the vertical vertical displacement. So it will look like a barrel-like form. This increases the tidal volume. But due to the effect of progesterone hormone, also there is an increase in respiratory rate. So because of increase in tidal volume by 40% at term and increase in respiratory rate, the minute ventilation increases by almost 50% at term. So this is the reason for chronic hyperventilation and respiratory alkalosis seen in pregnancy. So this respiratory alkalosis, there is compensated metabolically by decrease in bicarbonate up to 18 to 21 millimoles per liter. Because of secondary to decrease in PaCO2 because of respiratory alkalosis, there's increase in PaO2, which increases the gradient between the mother and the fetus, and this improves the maternal fetal gas exchange. Next, in respiratory system, there is 25% decrease in expiratory reserve volume, 15% decrease in residual volume, and 20% decrease in functional residual capacity. Plus, there is a 20% increase in oxygen consumption level because pregnancy is always an increase there is an increase in basal metabolic rate. So because of this, there is rapid desaturation usually seen during rapid desaturation and during periods of apnea. In fully pre-oxygenated healthy non-pregnant adult, the desaturation occurs in 8 to 9 minutes. But in healthy person at term, the desaturation occurs in 3 to 4 minutes because of the previous reason. And in morbidly obese female at term, desaturation occurs at almost 98 seconds. Coming to the airway in pregnancy, there is usually edema and hyperemia of the oropharyngeal mucosa. There is glandular hyperactivity and capillary engorgement. All these are because of the hormones, estrogen, progesterone, and relaxin. So there is increased risk of difficult and failed intubation in pregnant patient. Coming to the hematological system, the pregnancy is usually relatively a hypercoagulable state because there is increased activity of factor 1, 7, 8, 9, 10, and 12 by almost 100%, but anticoagulant activity is decreased. So these are the reason why there's increased risk of DVT in 1 in 1,000 deliveries, and maximum it is seen at 4 to 6 weeks postpartum. As total blood volume increases by 45% and plasma volume increases by 15%, the RBC volume increases by only 18 to 20%. So as the plasma volume increase is greater than increase in the RBC mass, there is hemodilution, and this is the reason for physiological anemia of pregnancy. The ESR and the blood viscosity is usually increased. Next, in the GIT system, in GIT, the lower esophageal sphincter pressure is usually decreased because of the displacement of the stomach upward and also because of the relaxant effect of the progesterone. The barrier pressure, which is the difference between the lower esophageal sphincter pressure and the gastric pressure, since the lower esophageal sphincter pressure is decreased, the barrier pressure is also decreased, which increases the risk of gastric reflux and heartburn. In pregnancy, the gastric acid secretion is decreased, the gastric emptying as no change or slightly decreased, and the GIT function, it returns to normal in 24 to 48 hours immediately after postpartum. Coming to CNS, there is usually compression of the inferior vena cava by the gravid uterus. So this increases the venous pressure. The epidural veins are engorged because the venous blood is diverted through the vertebral venous plexus, plus the epidural volume is decreased. So because the volume is decreased, there can be an extensive spread of the drug. So this is the reason why there is a decreased requirement for LA, local anesthetic, when administering spinal or epidural during pregnancy. And also there is increased sensitivity of the nerve fibers to local anesthetic. In the CNS, the changes seen are epidural space pressure is increased, the CSF pH is increased, the sensitivity to local anesthetics is increased. What decreases is the epidural volume, the local anesthetic dose requirement is decreased, and the CSF volume is also decreased. Next, coming to the renal function in pregnancy, usually there is an increase in renal plasma flow, the GFR, urine volume, and also glycosuria and proteinuria are noted. And also there is bicarbonate excretion, increased bicarbonate excretion because of respiratory alkalosis. Weight gain in pregnancy is usually about 10 to 12 kg. In a musculoskeletal system, as the uterus enlarges, the lumbar lordosis is enhanced. It is usually to maintain the women's center of gravity over the local extremities. The considerations during anesthesia, position, supine position should be avoided after 20 weeks of gestation, and uterus should be tilted to greater than 15 degrees. The drugs, propofol, induction dose is decreased, elimination half-life is unaltered. In thiopental, induction dose is decreased, elimination half-life should be prolonged. It will be prolonged. Volatiles, the minimum alveolar concentration will be decreased and the speed of induction will be increased. Succinylcholine, the duration of blockade is unaltered. About chronotropic agents and vasopressors, is usually decreased sensitivity in pregnant patients. About tracheal intubation, there's increased rate of decline of PaCO2 during apnea. PaO2 during apnea. Smaller ET tube is usually required. There's increased risk of difficult or failed mask ventilation. There's also increased risk of difficult or failed intubation with traditional laryngoscopy, and also there's increased risk of bleeding with nasal instrumentation. Consideration with neuraxial anesthesia, technical consideration, as there is increase, there'll be lumbar lordosis will be increased. The apex of the thoracic kyphosis is at a higher level. Then the patient should always be positioned in the lateral position. In hypotension, there is decreased sensitivity to vasopressors. As I told before, the local anesthetic dose requirement, the subarachnoid dose is usually reduced by 25%. Epidural dose is slightly reduced or it can be unaltered. That's it, sir.
You finished?
Yes, sir.
Okay. So what I would suggest is you have mentioned beautifully all the points, but my suggestion would be to mention the cardiovascular system changes. Correspondingly, immediately you say what are all the anesthetic implications. Like that, respiratory system changes. Correspondingly, what are the anesthetic implications? Like that, if you compare each and every system or include the anesthetic implications then and there, instead of accumulating it at the last and then mentioning the few points, you won't miss any points and it will be more appealing to the examiner to say that you have recognized that. So I have almost got a ready-made answer for you for that.